Welcome to the second presentation discussing preparation of patients for cardiac catheterization. Cardiac catheterization is a maneuver done through cannulation of large peripheral blood vessels, usually the femoral artery and vein, but can sometimes be the subclavian or jugular veins, with introduction of catheters and guide wires through sheath to reach the heart under fluoroscopy. Pediatric cardiac catheterization can either be diagnostic or interventional. Diagnostic catheterization aims at invasively assessing hemodynamics, while interventional catheterization aims at closing a cardiac defect, dilating a stenosed valve or vessel, or insertion of stents. How to prepare the patients? First, patients should be admitted 24 hours before the scheduled procedure. Please ensure to write down that the patient is admitted to the cardiology unit and the barcode of the patient is carrying the cardiology unit. A faulty barcode will carry a medical legal responsibility. Second, you have to revise patients' documentations. Please revise the referral letter, which states the type of catheterization for which the patient is referred, and also ensure that the patient is referred to our hospital. Revise patient's echocardiographic report and other investigations that may include a multi-slice CT scan, a transesophageal echo report, and of course, if the patient has done previous operations, please ensure to be aware of all the previous operation details. Revise with the patients all the medications. Patients on aspirin or warfarin therapy should be stopped 3 to 5 days prior to catheterization. Clexane should be stopped the morning of the procedure. And anti-failure medications should be continued except only in the period of pre-procedural fasting. Also, please revise if the patient is having any concurrent medical problems. Patients with previous recent stroke should have a neurological consultation and should be reported to the anesthesiology team, as anesthesia carries a risk of cerebral hypoperfusion. Also, patients with nasopharyngeal abnormalities may have difficult intubation. Patients with superior vena cava obstruction should not have a jugular access because of risk of bleeding, and any patients with bleeding, diathesis, or known hematological problems should have hematological consultation prior to the procedure. Then you need to do full medical examination to the patient, full cardiac examination, assessment of the oxygen saturation, and this should be done with and without oxygen supplementation in case of cyanotic heart disease. Please ensure that the patient is not having any chest infection, and also check for the oral hygiene and presence of dental caries, as this may be a relative contraindication to stenting. The pre-cath investigations needed include a CBC, CRP, PT, PDT, and INR. All patients must be having a chest X-ray, a recent chest X-ray, and ECG is mandatory in all patients, especially before ASD and VSD closure. All patients scheduled for interventional catheterization should have at least 1 unit of packed red blood cells prepared in the blood bank. Also, patients with relative thrombocytopenia need to have at least 6 units of platelets prepared in case of bleeding that might occur during the procedure. Afterwards, please inform the responsible interventionalist as well as the anesthesia team with all the preceding items. In the morning of the scheduled procedures, patient's guardian should sign consent for the catheterization. Sometimes we need a high-risk consent, and this would be requested by the anesthesia team. Also, patients should have been NPO for at least 6 hours before the procedure, and please arrange for an ICU bed in case of a high-risk patient. Now, after doing the catheterization, what follow-up would be requested for the patient? Immediately after the catheterization, vital data should be followed up on hourly basis for the first 4 hours and then on close intervals. Warmth and pulsations of the lower limb must be checked on 4-hourly basis. Also, bleeding from the puncture site must be closely followed up. Patients can be started on oral feeding once fully conscious, and ambulation should be encouraged as soon as possible. A cold, mottled limb with weak or absent pulsations necessitates an urgent Doppler examination with documented vascular surgery consultation. And in case of bleeding from the puncture sites, you need to do a good compression plus or minus blood products transfusion in case of massive bleeding plus or minus vascular surgery consultation. In patients with ASD or VSD closure and those with the stent inserted, they should be started immediately on heparin infusion or therapeutic calixane for 24 hours after the catheterization, and then they will be shifted to oral aspirin the next morning. The next morning, patients with interventional catheterization will have a follow-up echocardiography before discharge. All patients should be discharged on antibiotics for 5 days, plus or minus other medications as needed. Remember that patients with ASD, VSD devices, or inserted stent should be discharged on low-dose aspirin 3 to 5 mg per kg per day. All patients should be advised to have a file done in the cardiology clinic where they will be followed up according to the established protocols. Thank you.